the spine. If you look at your spine like this, is the top of your cervical spine. So the spine is a series of lamina, which are in the back of the spine, and cervical vertebral bodies in the front. And the spinal cord goes down the central canal like that. But this actually, the spine sits on, the head sits on top of the spine like this, on the cervical spine. In fact, there's a joke that so much of neurosurgery is spine that neurosurgeons, cranial surgeons are actually spine apex surgeons. They make that joke. But what's interesting, a lot of the abnormalities of what are called the craniovertebral junction, where the skull meets the spine. It's the craniovertebral junction. You can see the bottom of a skull has what's called the foramen magnum, and the brain stem sort of stops and becomes the spinal cord, and then the spinal cord goes down this canal. So this is kind of what, in a full craniocervical model, it looks like. Well, diseases at this junction, this craniocervical junction, are actually, that's a specialty people have at the craniovertebral junction. And what makes it so interesting is it involves the brain, involves the spine, it involves the vertebral arteries. There's a lot of anatomy there, including the cranial nerves. And it's really a beautiful spot to be operating because of the complexity of the anatomy and the complexity of the pathologies. One of the most common is a Chiari malformation. One of our illustrious brain turns this summer asked if I could talk about Chiari malformation. And so I said, sure. So we figured we could talk a little bit about Chiari, and I'll show a video of a Chiari decompression, which I think you really enjoy. The problem is, hold on, it's Langer. You guys need me? Oh, okay, that's fine. I'll be down. I'll be back as soon as I can. I'm just running 2 rooms, so I'm trying to do 3 things at once. In any case, I'll show you this case as quickly as I can. We'll get on with it. So this is a Chiari malformation that this is a Chiari decompression of a type 1. You hear me, Melissa? You still hear me?
Yeah, we hear you.
So this is a 35-year-old male who had intermittent vertigo, meaning that the room was spinning every time he put his head back. And that's not actually a typical symptom. The most common classic symptom of Chiari malformation are actually neck pain, really bad suboccipital, meaning pain in the back of the neck or up high on the skull. Often when people are bearing down, having a bowel movement, exercising, it can be less relevant when they're less significant when they're flat, but you can have bad neck pain. It can often radiate into the shoulders. People can get numbness of their hands. With very severe cases, you can get myelopathic, meaning have weakness of your arms and legs. But this gentleman had basically intermittent vertigo whenever he put his head back. And there's a dynamic nature to this, and that's why he was probably suffering from this, because when he puts his head back, he makes the anatomical situation worse. If you look at, remember the craniocervical junction, just like I showed you before, if you remember, if you look at my picture over here, is built on a skull and a spine. And that's what you're really seeing here. This is the bottom of the skull. This is the foramen magnum, which I showed you before, coming out of the skull right here. And then this is the C2, this is the dens, which is the top of C2, and then the lamina in the back, the vertebral bodies in the front. And what happens is in Chiari malformations, the cerebellum, or particularly cerebellar tonsils, crowd the foramen magnum and the spinal canal. It's unclear why this happens. It's unlikely, and most of these are developmental, meaning your skull may fuse before the cerebellum finishes growing, or the cerebellum continues to grow into the canal and causes compression of the brainstem. There are congenital Chiaris that we see in children that are much more severe, where we see tonsillar tissue way down low in the spinal canal, which is a much more risky and more devastating problem. But in these adult acquired Chiaris that are later in life, you're probably born with the propensity to develop this, or maybe you have this over time, and just from the CSF pulsations, the tonsils begin to go south. If you look at this axial view, this looking horizontally across the screen where this green line is, what you can see here is the brainstem. These are the two vertebral arteries on the sides. And you can see this tonsillar tissue, this kind of linear tissue is cerebellar tissue. You can see what are called the folia of the cerebellum. And these shouldn't be here. These tonsils should not be here. This canal should be wide open. The brainstem should have plenty of room with spinal fluid all around it. You can see on here that it's really these tonsils are taking up space and sort of pushing into the brainstem. And you could hallucinate that if you put your neck back, as you tilted your neck, you might kink that more, and those tonsils might push on the brainstem a little bit more and cause vertigo. And so that was the assumption that we were making about this case. The rest of the spine looks normal. You can see the spinal canal there's no cord compression. The spinal cord comes down here. There's spinal fluid on each side of the spinal cord. You can see this white is spinal fluid. What you don't see is spinal fluid here in front of the brainstem or behind the brainstem or behind the tonsils, because all the tissue is there and it's sort of squeezing together. And it's all, in all likelihood, the movement that he is making makes it worse. So when we operate on these, we put people in the prone position. Supine is on your back, prone is on your belly. The way you remember that is when you hold a bowl of soup, you hold it up. That's how I remember supine is up. So soup is like I'm holding it up like this. So I'm holding up, that's supine. Prone is on your belly when you're on your stomach. And we prone, we come in from this direction. And the goal is to remove a significant portion. Let me stop sharing for a second. We remove a portion of the skull back here and open this space up. Then we open the dura, which is the covering of the cerebellum and the spinal cord, to relieve that pressure. We shrink the tonsils, meaning we actually coagulate them to shrink them, and that takes the pressure off the brainstem. And then we put a patch in. We use alloderm, which is basically human skin that's been decontaminated, basically, and we use that as a dural patch. So let's share my screen again. So let's watch the movie. It's one of this, unfortunately, there are a lot of Chiaris that probably are not causing symptoms that people have surgery for. So this is a gorgeous video. The top of the head is this way. The legs are to the left. This is the midline. So I'm going to come down on the spine here. I'm sorry, my bad. This is the skull up here, and the legs are down this way. So you're going to start to see the back of the skull here, the C1 arch, which is the arch of C1, which is basically this right here. This is the arch of C1, and we're going to come down on that bone. Let me just stop sharing my screen for a second. So the dens sits right here which is the top of C2. The arch of C1 is like a circular, it's like a peg and a ring. And the C1 arch is a ring. In the back, there's a lamina of C1, and we're going to come down on that. And then you also will see the back of the skull. So you see the skull, and you'll see the C1 arch. This is where we're operating from here to there. Got it? That makes sense, Melissa?
Yes, it does. Thank you.
Tell me if you're confused. Because I can't
great.
thousands of people out there. Right, so again, here's the skull. C1 arch is going to be about here. This is a Bovie. This is a coagulating tool we use to open up take the muscle down to prevent bleeding. This is the back of the skull. And now you're seeing that C1 arch. This is bone. And where you can see it's mobile. Then now it's really at high mag, you're seeing the arch of C1. So now we're just going to resect it. We use this little kerosene punch to create some space, and then we literally drill it off with this drill. And we're just going to remove that bone. It gives more room back there so we can remove the dura. Here's the drill on the other side. So we take the two pieces off. So I'll stop that again. Let me stop sharing. So what that is we are taking off this bone from about here to there. The spinal cord sits in here, and we're removing that bone in the back, that lamina, to give more room right there. Does that make sense, Melissa?
Yes.
Sort of like this. And
if anyone's confused, you could write it in the chat, but I think you're doing great, Dr. Langer.
One cut here, one cut there, and then we're going to remove that arch.
You're too good to be confused, apparently, to be confusing.
Now we're going to remove that whole arch of C1. That's the bone. And now we're seeing the dura, which is the covering of the high cervical spinal cord. It's down in here. Now we're going to remove a little bit more bone just to get a little more lateral to give us as much room as possible. Now we're taking more muscle off the back of the skull here. You can see the size. It's about we're going to make about a 3 centimeter opening in the skull, height-wise. We're marking it. Now we're making a couple of burr holes. This is another type of drill bit. And now once you get down to the dura, you can you can do a craniotomy. You can remove this piece of bone. So we're just drilling that bone out. This is the dura of the cerebellum back here now. So now we're just basically this is called blue lining. We're basically taking the bone all the way down to the dura until it gets really thin and you can see through it. And now you're starting to see that bone give way. The bone gets so thin there, and now we're just going to remove that last piece of bone of the skull. So this is basically a portion of the skull. And that's the size. It's about, looks like 3 inches. Actually 3 centimeters, I should say. We're going to expand. Now we're just expanding the opening a little bit. We want it to be a little bit larger. So again, here's the midline. This is the right cerebellar hemisphere because we're prone. Left cerebellar hemisphere, arch of C1 removed. And now you're seeing the right cerebellar hemisphere and left. And now we're opening the dura, which is the covering of the brain and spinal cord. A little bit of bleeding. See how it's almost translucent. You can see through the dura and you can see the cerebellum there. And now as we cut through it, you can start to see spinal fluid come out. You can see the cerebellum underneath there. It's actually beautiful surgery. It's just so gratifying. Now you can start to see the cerebellum. We don't want to injure it, so we put a little what this is called a cottonoid. And now we're going to open up in like a V. We're going to open up the dura kind of like that, and take the rest down below C1, because the tonsils are down into this space here. You got it, Melissa? You understand?
Yep. Okay. Everyone's loving it.
Now we're looking down into the intracranial space. That's the bottom of the cerebellum. Now we're going to make more of a straight cut here. This is going down to the spinal cord and the upper cervical spinal cord. And then we have to connect these lines like a Y. So one cuts this way, one cuts this way, and one cuts there like a Y. It's got three different arterotomy lines. Sometimes you can get some bleeding here because there are little arteries that cross. So we put these clips across the dura to prevent, usually venous actually. They're veins that sit in the dura. You can see a little bleeding there. And now we're seeing everything. So here's one cerebellar hemisphere here. Here's the other, the left, the right. And these, the abnormal tonsils right here. These should not be there. This tissue right here is abnormally low. And we have to get below them. So there's the bottom of one tonsil, and here's the bottom of the other. And this is the bottom of the medulla and the top of the spinal cord. So now this is that pressure against the brainstem. This is the tonsils. Here you can see one of the posterior inferior cerebellar arteries. And you don't want to, you can get a bad stroke if you coagulate those arteries. So really work hard to protect them. And now we're just elevating these tonsils off the brainstem. This tissue is useless. That's the vertebral artery right there. This is called the accessory nerve. This is the vertebral artery. The accessory nerve allows you to shrug your shoulders. It's one of the lower cranial nerves. It's called the spinal accessory nerve because it emanates from the cord and it travels intracranial before it goes to your shoulder. So now we've shrunken one tonsil, now we're shrinking the other one back. But you can see here's the posterior inferior cerebellar artery on the other side. And you have to be really careful. This is the bottom of the obex, which is the bottom of the fourth ventricle, the choroid plexus, which makes spinal fluid. So when we're all done, now we've got, see how spinal fluid is sort of circulating around, and the tonsils have been shrunken back. They used to come all the way down to here, and now we've shrunken these back with cautery. There's no more compression. Spinal fluid can come down easily, and now we've created all the space around the lower medulla and spinal cord. In fact, if you look at before and after, here were the tonsils before. Here are the bottom of the tonsils here, right there. This is the This tissue right here is right here. And we've basically shrunk these all the way back up to about here. So now we're seeing the entire lower medulla and spinal top to the spinal cord with no compression by the tonsils. Does that make sense, Melissa?
Wait, Dr. Linger, a few people are asking how you went about shrinking the tonsils,
So if
and
you
also
go,
why you shrunk them rather than removing them.
well, you can remove them. It's just easier to just coagulate them. What I'm doing here is this is what's called a bipolar, and I'm just using heat to shrink them back. See that? It's just safer. When you start to try to remove them, it bleeds more. You're basically, here you go. They're coagulating them. I'm just putting heat on them, and they shrink back, kind of like, tissue paper. When you burn it, it sort of comes back, and it just basically shrinks them down with heat. And you can see actually little brown staining where the cautery was, and that just cauterizes that tissue and shrinks it down. You could remove them, but there's more bleeding and it takes longer actually. You don't have to remove them in their entirety. You'd have to shrink them enough back that they take the pressure off the spinal cord.
Is there a risk that after shrinking them, they could regrow,
No.
re-expand?
No, but it's basically, it's just you're using heat to take tissue away rather than, grossly removing it. It just shrinks them all the way down. The tissue's dead after that portion of it.
Got it. And the tissue is useless, so there's no harm in shrinking them?
No, it's the tonsils are inert. There are many, I would say 60% of the cerebral cortex, maybe more, and the vast majority of cerebellar tissue can be removed with no ill effects. You could have some temporary gait difficulty or imbalance or discoordination, but you recover it. And the tonsils themselves there's no known function that they serve. They probably do in some way, but you can tolerate removing them and shrinking them. And in bad, you can tolerate a tonsillar injury. If you injure the cerebellar tonsils, you probably wouldn't notice. This is
Got it. And does using heat inside the brain cause any deficit in general? People are wondering.
Burn something important. If you burn your speech area, you won't be able to speak. If you burn your visual area, you won't be able to see. But you can coagulate the tonsils because they don't have any known neurological function.
Got it.
This is a beautiful example of the posterior inferior cerebellar artery. This artery leaves from the vertebral and then takes this tonsil, what's called the tonsillar loop. It's a loop of the vessel that loops down around the tonsils. This is actually relatively low lying, but that's a great example of what the posterior inferior cerebellar artery looks like. And then we have to put a patch in at the end. I'm not sure if we show that. Maybe we do. 42 seconds left of the movie. Yeah, so this is this alloderm patch. This is actually human skin that's basically been heated and lyophilized, meaning it's dried out completely and cut very thin. And then we rehydrate it in the operating room. It has no immunological, all the proteins are removed from it. So it's just basically primarily collagen. And you can just easily use this, and we sew this to the dural edge because now we want to create like almost like a billowing pillow to create more space so that spinal fluid can circulate completely. So we've removed the bone, we've expanded dural, we put a patch in, and we've shrunken the tonsils. So the combination of all three things, 95% of the time, gives that brainstem more room. And that's what we do with here. I want to thank my two residents, Kevin Kwan, who's going on and doing a spine fellowship at Columbia with a guy named Larry Lenke, who's one of the world's best known deformity surgeons. Emery Chilwell, Ricky was one of my old residents and fellows who's now at Jamaica Hospital in Queens. He's just an outstanding doctor and surgeon. And Elaine Kleshkova was one of our students from Hunter College a couple of summers ago who helped put these together. She was pre-med. I'm not sure what medical school she's in, if she's gotten in yet, but she just did a terrific job editing these videos, as Melissa and her team are going to be doing this summer. Right, Melissa?
Yes, we're very excited.
Okay, so I'll stop sharing.
Do you have any time for questions, or?
Yeah, sure.
Do you have to go back to surgery? Okay, so people are wondering where that that skin patch came from? Is it made in a lab? Is it taken from somewhere?
Commercially available. There are companies that harvest tissue. You know, not retinas, corneas. Starting with the eyes, corneas are harvested. Then people can donate there. If you're an organ donor, there are many things besides your heart and lungs to be donated, and the skin can be harvested and then thinly sectioned and turned into we can use this to repair deficits on the dura or all sorts of things to do with it.
Very cool. And people are wondering why you don't put
sites to watch our neurosurgery. The answer is yes. If you go on to Lenox Hill Neurosurgery on YouTube, we usually post a lot of these. In fact, we haven't. I'm going to ask our summer interns to probably post more. You know, we're going to create a bunch of new videos this summer, and we'll probably post new ones. But there must be 30 videos on our YouTube site. Also, last year's brain turns we showed some surgical videos. In fact, I had one to show last night. I realized I showed it last year, so I decided not to show that one. But some of those videos are on the Lenox Hill Brain Turn site from last year of the virtual OR. So yes, there are tons of videos, and YouTube's has. I mean, if you go on neurosurgery videos, it's like there's more neurosurgery videos than I care to admit. Everybody's showing off what they're doing. So there's tons of stuff there. Some are better than others. Ours are the best by far. So,
obviously. People are wondering what you did your fellowship in.
My first fellowship I did in open vascular neurosurgery, carotids, aneurysm clipping, ABM resection. My second one I did in catheter-based vascular technique. So putting catheters into the brain vessels and treating aneurysms, primarily AVMs, stroke, using catheters. Because vascular neurosurgery has really evolved from more open to endovascular approaches. So I did my second fellowship after I was out of my residency 10 years.
Well, long time.
Bet you didn't know that.
Didn't. Jessica was wondering, would the appearance of the malformation or symptoms differ, and how would the treatment differ if a Chiari malformation caused by spina bifida in a child?
Well, spina bifida is a congenital problem where you have a developmental problem of the spinal cord. Spina bifida means that a bifid spine. It's really related to the structural spine abnormality in the midline, usually down in the lumbar spine, where the two lamina don't fuse, so they have an opening in their spinal canal. And there are differing forms of spina bifida. Some very severe, where they actually when the baby is born, there's actually an open spinal canal, and there's a large meningocele or lipomyomeningocele, which is a fatty spinal tissue mass. And these are very devastating. In fact, fetal surgery, which is remarkable, where they're operating on babies in utero, where they'll go in with fetoscopes and operate on little fetuses. One of the areas that's showed a lot of promise. When I was a resident in the 90s, this just started, but there's been really good data that these kids do really well if you close their myelomenogoceles, because you can't leave them open. They'll get infected and die of meningitis. So you have to close them. In the old days, when I was a resident, the baby was born, we used to open the sac, imbricate it, sew it in, and close the skin over it. Sometimes really bad ones needed patches and skin patches because you didn't have tissue. But now with fetal surgery, they're closing these in utero. The problem with the spina bifida case, though, is they can have what's called tethered cord. The cord is sort of tethered to tissue down the lumbar spine, way down the low back. And that can also be associated with Chiari. That when there's that extra tension, the tonsils get kind of descend. And those are very severe forms of Chiari. They often have neurological deficits associated with them, not just pain or discomfort. And they are unfortunately usually not the greatest outcomes to fix. Those are called type 2 or even type 3 Chiari malformations. The ones that adults get in general are type 1, which are just the tonsils themselves. They're usually not associated with a spinal dysraphism or spinal problem. They can be associated with what's called a syrinx, a cervical syrinx or a thoracic syrinx, which is a fluid collection inside the spinal cord that can cause symptoms. But in general, the first sort of treatment when people have deficits related to Chiari is the decompression up here.
How long does this procedure usually take?
About 2.5 to 3 hours.
Okay.
You don't have to put
And
the,
people are also,
we can put a mesh in. We often leave it open and just put a mesh to cover the skull back there, but you can't feel this hole. This hole is so down low when it's basically way down here. If I bend my head, you could not see the hole. Because when you think about it, you're looking at the skull in the back like that. So the actual hole's here. And there's so much muscle covering it. You think the hole's here. No, the hole is way down there. So anatomically, you couldn't even feel the hole. In fact, if you feel a little prominence on your skull back there, that's called the inion. It's a little proud spot in the back of your skull. The inion is right here. And it's that where our opening is way below that. So if you can feel that inion, you can feel your skull kind of slope away. You press, and then you start feeling muscle, which is those muscles, these paraspinal muscles, and the sternocleidomastoid called the sternocleidomastoid muscles. These muscles are covering all the skull back here, so you can't feel that hole. We often cover it with mesh that muscle doesn't sort of grow into that hole, which can cause headaches. But in general, it can be left open.
do you reattach the arc of C1?
No, you don't need it.
Cody keeps sending his question. So in children, hydrocephalus is commonly seen with Chiari malformation. So does Chiari malformation commonly cause the hydrocephalus, or are the diagnoses independent of themselves?
Good question. There's probably there's definitely an association. Hydrocephalus can cause Chiari for sure, because you have extra pressure and it can cause the tonsils to descend. On the other hand, it's possible that Chiari can cause hydrocephalus. What we do know is if you drain spinal fluid chronically from the lumbar spine, you can create a Chiari. You're creating a negative pressure, and so the tonsils can descend from a negative pressure below. One of the most dangerous things you can do is do a lumbar puncture in someone with a Chiari. People can die from that, because what happens is you create a negative pressure below the tonsils, and they acutely descend, and it can cause acute compression of the brainstem. You can stop breathing. So people with Chiari should not have LP. In fact, sometimes pregnant women who have spinal anesthesia or epidural anesthesia from babies can be a little scary sometimes, because Chiaris can be undiagnosed. I don't want to scare the hell out of everybody. That can happen, but in general, you have to be careful with doing lumbar punctures on people with Chiari malformations.
Are there any symptoms of Chiari malformations? Like how would someone know that they have this?
Headache, hand numbness, tingling, shoulder pain, bilateral usually.
And Sky was wondering if the patient had any side effects after this procedure, and if so, what were they?
It was perfect. No pain, no anything. He went home the same day. No, it hurts.
Wow, that's awesome.
No side effects. The biggest risk is a spinal fluid leak, but we have to be really careful closing the dura and getting a good dural patch in. We can also put tissue glue around it when we're done, and then a multi-level closure to eliminate dead space that fluid can't sort of leak in somewhere, leak out the skin. But that's the thing we really need to try to avoid. Spinal fluid is produced at about 15 cc's an hour, so we can drain all your spinal fluid and it'll all come back within about a day. So yeah, it hurts. This operation does hurt. Recovery time is about 3 weeks when you really feel better.
What is the tissue glue made of that you glue?
Usually fibrin, some sort of fibrin glue. There are also some newer dural glues that are more synthetic, that cause a chemical reaction between themselves and the dura, which they're like organic chemistry things. I'm not totally up to speed on how they work.
And is a Chiari malformation hereditary? And how common are they?
Probably not. They're rare. They're uncommonly common. Probably I don't know what their it's probably 1 out of maybe 5,000 people have a Chiari, something like that. I would say. Maybe higher than that. The incidence is probably around. You can look it up. You guys can tell me.
And Michael was wondering, is it your practice to always do a Duroplasty with a Chiari decompression?
We do. It's not, not everyone does that. Some people just take the bone off. Some people, don't open the dura. Some people open the dura and don't do a dural patch. I think if you open the dura, you really should put a patch in. I think you're less likely to have a spinal fluid leak. But there is controversy about this, and I'm not really an expert because it's really a pediatric disease. But I do a fair amount of Chiari, but I do the more straightforward ones that are mostly adult, and I patch everyone, and I do a full suboccipital and C1 arch decompression. That's just my practice.
Okay. Then Ashish was wondering, how would we know that we have just shrunken the tonsil and not the parameters of the cerebellum? Is there a margin to follow?
Yeah, I mean, that's a good question. I mean, the tonsils are well-defined anatomically. You know when you're in the tonsils, you know when you're in the cerebellum. They're totally separate. So, and you don't, shrink them enough that you can get, you're not really that, you're close to cerebellum, but there's usually a couple of centimeters of tonsillar tissue that are left. So there's plenty of room. You can you could actually coagulate part of the cerebellum without a problem too, though. I mean, you wouldn't notice, but
There would be no deficits?
no, not unless you did a huge chunk, and you can remove a fair amount of cerebellum with no deficit, for sure.
Wow. Also, Brecken was wondering how old this patient was.
35.
I think 35, yeah.
There you go. Double ANS has prevalence slightly as of 1 in 1,000. So I said 1 in 5,000. I was close. I was within an order of magnitude.
Yeah. You were right.
Thanks, Kristen.
Dariana was wondering, can a Chiari 1 appear and then leave when the doctor checks an MRI?
I mean, I think probably it has to do with the technique of the magnet and what they're calling a Chiari, because it's sort of subjective how low the tonsils are. I haven't seen one go away. The only time they go away is if they're caused by a lumbar drain or drainage of spinal fluid from below, and then you remove the shunt or the lumbar catheter, and then the tonsils resume their normal place. I'm sure there are cases of people who've had one and then they miraculously go away, but it's probably those are the ones. But that's what people write up, so you think it happens all the time.
Then while watching the surgery, a few people are writing in the chat, when you're drilling through bone, where does the debris go? And also, is it fine to just drill through muscle? Will that regrow or will there be any deficits?
Also, we coagulate it, tract it. We drill with bone, we're irrigating constantly and sucking the bone dust out. We don't like to leave the bone dust in, although undoubtedly there probably is a little bit left in there. But we like to, if it's the subcutaneous tissue, it's not a big deal. We really don't like bone dust to get into the spinal fluid space. It could basically cause inflammation or block spinal fluid absorption. So we really don't want bone fragments in the spinal canal.
Then Mitten was wondering, can mild spina bifida go undiagnosed? And if so, would the child have any health problems? And what's the life expectancy? Yeah,
I mean, spina bifida can go undiagnosed. Very often, when babies are born, they always check for a birthmark or a sign of a spina bifida on the lumbar spine, but they can often go into young adulthood. They usually have undiagnosed spina bifida. It's very mild, but they have a tethered cord. And since the cord is tethered, they start developing leg weakness or incontinence or gait problems either in late childhood or even early childhood. It can come on anytime. I've seen adults present with tethered cords and undiagnosed spina bifida at times also. And we untether those cords. There's a whole field of cord untethering for mild spina bifida. And, it's one of the more common operations that pediatric neurosurgeons do.
Cool. Yaira was wondering, if the prevalence is 1 in 1,000, is there any precautions taken before LPS to make sure that there's no Chiari?
Not really.
You just need to risk it?
Yeah. I'm going to have to run back the OR, unfortunately. They're calling me. So can you may be able to carry this on your own. What's the next section at 11?
The next section is Dr. Pramanik is the chief of neuroradiology, and he'll be speaking to us.
You may want to come on a little early, that's all, rather than having you guys wait around. I'll call him. Everybody enjoying this so far? Make sure you put us on. You got to buy merch. It's not.
Yeah. Buy merch.
I'm actually done a little early. I have to run back to the OR. So if you want to take over now and they can end early rather than having wait for you, it's fine with me. It's just up to your schedule. Yeah, I'll wait for you to come on, and then I'll buzz off once you get on, so I don't leave them without something. All right, thanks. Bye. No problem. I'll wait. So Dr. Prominent is going to come on. So you guys see, I don't want you to lose your day, have to sit around for half an hour. we respect your time too. And the fact that you all are making this effort to spend the mornings with us during the summer means a lot. This is the first step of your lives in some ways. And while it's all virtual, hopefully this will stimulate you and get you to want to come and see us in person. A lot of people have asked about coming visiting. You're absolutely welcome to come. Obviously, we can't take 1,400 people all at once. So once, probably in the fall and certainly next summer, please reach out, and we just have to keep a controlled version of it. Melissa was lucky enough to get it under the radar because she had people in high places. But other than that, it's hard to, we certainly welcome visitors, and we'd love to see you come visit us, certainly after the summer. As far as other tidbits, I think, respect the fact that hard work pays off, and, doing things out of the ordinary and taking some risk and making that extra effort matters. Yes, Kaja, you don't have to live in New York City. I don't know where you're going to stay when you're here, but you're more than welcome to come visit us no matter where you're from. And that's good. As far as getting in touch with us, I think that we have email addresses out there. How does that work, Melissa?
Yeah, we have, if you look at the Brain Turns Facebook page, there's ways to get in touch. Dr. Linger, I don't know if there's a particular email you want people reaching out to.
All our emails are available. You just have to.
Everything's available online if you just look for it.
And just email us. I imagine it can get a little busy, so we have to be, judicious. We have to really be careful. We can't have more than about 5 students at a time. But the best time to come actually is, if your parents made a trip to New York and you spent a couple days here. If you come in the summer, it's obviously more competitive because that's when everybody wants to come. But there have been people who have come in the last few weeks, just want to come in and stop by and come see us, and we're more than happy to do that. But as far as spending a full week or a month or a year here, we have 2 interns that spend the entire year at Lenox Hill. We have a summer internship face-to-face. This year we got very few, but next year we'll probably have it between 5 and 10 face-to-face. That's what virtual Brain Turns grew out of, was that we had our face-to-face interns, and during COVID we realized we couldn't do it. So that's what led us to start this whole program. So we'll probably continue to do the virtual Brain Turns, and then we'll hopefully expand on the face-to-face interns. As far as the people that are welcome, high school is a little early. It doesn't mean you can't do it. It's just that there's more to learn and less to gain. The best people that we would most want to have are actually medical students, because they can help us doing research and writing papers. But it's really college kids, especially sophomores and juniors, that are looking to apply to medical school, that want that kind of experience. Number one, you get to write some papers with us. Number two, we get to write a letter about you. And if you have a pulse and show up every day, you tend to get a good letter. And that helps you apply to medical school. So if you're in college and especially, we would obviously prefer a junior or a sophomore over a freshman. Senior college students have been here, but they are more likely to stay for a longer period of time. They're usually taking a year off, because either if you're a senior and it's the summer after your senior year, you probably already got into medical school, or you are planning on applying. And if you're going to medical school, then you aren't going to spend a lot of time with us, because you start med school in the summer and you want some time off. And if you're taking a year off, then we'd love to have you apply for our year out program. So yes, gap year students are welcome. Email, you just track our emails down, send us an email. We forward it to our administrative staff, and we'll hash through that probably, sometime in the fall to figure out what we're going to be doing next summer.
Dr. Linger, if you have to run at any point before Dr. Crummy gets here, I'm also happy to answer any questions about my experience here.
Because I like him.
Okay, sounds great. I'm not sure what IMG is, but a few people are asking about research opportunities.
Medical graduate.
Oh, so people are asking about that.
Yeah, we welcome IMGs. You know, there was just an article that came out in our literature, the contribution that international graduates have made to medicine and neurosurgery. You know, some of the most ambitious, hardworking students are IMGs. The trouble is there is an element of, you know, protect the interests of the American students first. But I think that if they're outstanding international graduates, we're all open to supporting them. In fact, we have a number of them in our department. So IMGs are welcome. Right now, my fellow right now is from Israel. I had a Lebanese fellow a few years ago, Ralph Rami, who's runs St. Barnabas Hospital in the Bronx. He now works full time here. So yes, IMGs are more than welcome to apply, and they're welcome to work with us. Plus, we get to do great trips. You know, they like us, so they ask us to go visit, which is awesome.
Sounds great.
As far as online research, reach out to Randy D'Amico. He's running a lot of that. So if there are any research things, you know, Randy's really running this. He's done a great job running Brain Turns, and he really has been doing a lot of the research stuff. So reach out to Randy directly.